Yeah, I think we can get started. This is Rush University Medical Center Division of Nephrology Renal Biopsy Conference for August 12th, 2021. Today's activity code is 483213. As usual, the patient has been de-identified. We don't have anything to disclose. We have Dr. Whittier remotely from Boston. We have Dr. Corbett remotely from Nashville. We've got Dr. Gastier. Oh, he's in the office. Okay, we've got some fellows remotely from the hospital, and Dr. Baxi and I are at Biopsy Conference Central here at our outpatient offices. We've got a great case today. It's going to be a lot of fun. It's a topic that we're seeing a lot of, and it's very timely and very interesting, without a lot of data, but it'll be a lot of fun to talk about. Dr. Shahzad is going to read the protocol, and we'll take it from there. Asim?
Right, sounds good. So the patient today is a 30 years old Asian woman who presents with new weight gain and diffuse swelling. Nephrology was consulted for evaluation of proteinuria. She has no prior medical issues and denied any hospitalizations or childhood illness. She reported an acute onset of 20-pound weight gain over the past 3 days with generalized body swelling. She denied any other symptoms prior to this and denied any over-the-counter medications use as well. A review of systems was otherwise negative. She was seen by a primary care physician, and her labs showed a serum creatinine of 0.67 and albumin of 1.2. The urinalysis was collected and showed 4+ protein, 2+ blood on dipstick, 5 WBCs, and 5 RBCs on analysis. The urine protein to creatinine ratio was 14.7 gram per gram, with urine albumin to creatinine ratio of 9.5 grams. No prior lab data was available. She was referred to nephrology for urgent workup. A kidney biopsy was recommended and completed 2 days after the presentation. A review of system, as noted above, was negative, except for the weight gain and diffuse swelling. Her past medical and surgical history were unremarkable. The only medication she took was loratadine 10 milligrams PRN for HA. She had allergy reported to penicillin, but the exact kind of allergy was unknown, and she stated it was severe when she was previously given. The social and family history was unremarkable. She was not a smoker, denied any alcohol use or drug abuse, no family history of autoimmune or kidney disease. She was fully vaccinated against COVID with Pfizer vaccine, and the second dose was completed 30 days prior to her current presentation. Her exam showed blood pressure of 110/68 with a heart rate of 80, respiratory rate of 12. She was afebrile, and her weight was 152 pounds with a BMI of 25.3. She appeared calm, healthy, and of a stated age. Heat exam was unremarkable. She had no appreciable lymphadenopathy, with lungs, cardiovascular, and abdominal exam also unremarkable. Her skin had no rash or bruising. She did have 2+ lower extremity edema and facial puffiness. The lab showed sodium 138, potassium 4.1, chloride 106, bicarb 25, BUN of 11, and creatinine of 0.67. Blood glucose was normal at 90. Total protein of 4.9 with an albumin of 1.2. Calcium 8.3 with a total bili 0.3. Alkaline phosphatase was 60, AST of 28, and ALT of 31. The lipid panel showed a total cholesterol elevated at 448, LDL of 294, the total triglycerides of 205. WBC count was normal with normal differential hemoglobin of 15, platelet count of 284 with normal coags. Her ANA was negative, and so was ANCA, MPO, PR3 negative. Anti-double stranded DNA antibodies were also negative. C3 was 129 with C424. SPEP and UPEP were without any monoclonal proteins. Hep B and C were also negative, and so was HIV and COVID-19. The UA show was yellow in color, clear, with a spec gravity of 1008, pH of 6, protein 4+, 1+ blood, 7 WBCs, and 3 RBCs. Urine protein to creatinine ratio of 14.7 gram per gram, with urine albumin to creatinine ratio of 9.5 grams. The renal ultrasound showed right kidney of 10.7 centimeter, left kidney of 10.8, without any hydronephrosis. A percutaneous renal biopsy was performed.
Boy, it doesn't get much more straightforward than that. Any questions for Asim? I mean, I suppose you probably ordered, I don't see a PLA2R, but as rapidly as you got this patient going here, there is you probably had the patient biopsy by the time the blood would even be drawn for that. So, Dr. Whittier, why don't you walk us through this case from Starbucks in Boston?
Yeah, thanks. I'm over here next to Fenway Park. The Red Sox are about to start at 4 p.m. So hopefully it doesn't get too crowded right when they start. Yeah, there's a pretty straightforward case, as you said. You got a young one with sudden onset of nephrosis, and your big three, with a negative serologic workup. And your big three are usually minimal change, focal sclerosis, and membranous. And to try to narrow those down further, the presentation can sometimes be helpful. Demographics would be with Black patients being a little bit more on the FSGS side, and whites being in the membranous, but a young person of really any ethnicity who presents with this sudden onset of nephrosis. I mean, the top 10 really should be minimal change disease. A close number 11 might be in the FSGS range, I would think, more so than membranous, because a tip lesion or some of the other FSGSs without renal failure can also have foot process effacement and present in this way. We think about some of the other FSGS lesions, such as collapsing, and we usually don't see that as often without renal failure, but if it does present early enough, then you could have that as well. There's nothing here else to suggest a secondary disease, not just because the serologic workup is negative, but also she hasn't used NSAIDs, she doesn't have any of the precipitating factors for it's sort of a viral illness or a COVID-like illness to suggest another lesion. She did get vaccinated, but everybody's getting vaccinated around this time. Post-vaccination reports have occurred, and I don't know, I think I've seen quite a few glomerular diseases from minimal change to FSGS to all sorts of things. And I think that's kind of still questionable on whether there's a causation there or just an association. But anyway, like I said, I think my top 10 here in a young woman sudden nephrosis, it'd be minimal change. The presence of blood, we always talk about this, and then we always go to Sarah Jandeska, our pediatric nephrologist, and she always says that you can see it. I think it's somewhere in the 10 to 20% range where you can have some microscopic hematuria even with minimal change. So that doesn't sway me away from it. And so that's still in my top differential.
So, in the old days, we used to have this conference in a little conference room in the hospital with a projector, and we had a chalkboard there, and Dr. Whittier would get up and he'd say, number one and number two and number three, and he'd put it on the board. Or sometimes 4 and 5, he'd always have the diagnosis. This is my top 5. And he'd say, the number 6 is this. He was so sure of himself. So now he's taken it to another level, and he's given the top 10 as minimal change disease. I got to tell you that more often than not, Bill was wrong when he would say.
Well, I was about to say that it's guaranteed to now not be minimal change. So everybody else better come up with some better things than the differential.
Yeah, but it's still very funny. Dr. Gashty, what do you think about this case?
I think Bill covered the differential pretty well. I think the other two things that support minimal change is the cholesterol is really high and the blood pressure is normal. So my differential is the same as Bill. It doesn't change.
Nothing to add.
I didn't say amyloid, but I mean, what do you think about that, Casey?
30-year-old.
Yeah,
I mean, this would have to be secondary. And I mean, why? I mean, that would be number 12.
So,
Roger?
Yes,
Roger?
Yes.
Can I ask the discussants a question? I note that about 5 grams of the total protein excretion is non-albumin. Now, it is said that minimal change disease is almost exclusively albuminuria. Why is it that this patient has 30% of the total protein excreted of a non-albumin character? Does that have any importance in differential diagnosis?
I'm glad I'm not a discussant, so I don't have to answer that. Bill?
Oh, well, I can take it. I'm not sure if it's going to be right, but I'll take a stab at it. In diabetic nephropathy, we think of classically this 30% being non-albuminuria, but in minimal change, I know that it is often more albuminuria, which is probably why your serum albumin drops so low, or one of the reasons, not only just the rapidity of the disease, but also because it's chiefly albuminuria. And here you're right, we have a little bit more non-albumin proteinuria. So either the test was a little bit off, or is it possible that there's some tubular damage and we have some tubular proteinuria? We don't have any evidence of ATN by her serum creatinine. Or is it possible that she has some non-albumin proteinuria that's not from lack of reabsorption from tubular proteinuria, but even an overflow proteinuria? But we also have a urine immunofixation that is without any monoclonal protein. So I think it's kind of hard to explain. I'd like to see on the UIEP what the percent albumin is to see if it corroborates with our AC and PC ratio. I don't know, Asim or Dr. Shahzad, if you have the percent albumin on your urine electrophoresis, because that might also say that maybe it's 90% on that, and then we're just kind of dealing with the regular inadequacies of the protein creatinine ratio.
Yeah, I think that's a great point. I think it was in terms of the part of the reason why it's kind of probably 9.5. It was above the cutoff of the lab, so it's probably more of a lab phenomenon than. And so if we were able to actually quantify, I think there would be much closer to the total protein. There'd be very minimal tubular proteinuria or non-albumin proteinuria.
Dr. Glassick,
As you might expect, it was a bit of a trick question because I don't know that we can say for sure what her urinary albumin excretion really is based on an immunonephrolometric method, which tests only for the immunologically reactive albumin in the urine. The remaining protein may be just non-immunologically reactive albumin. This would be shown up in a urine protein electrophoresis pattern. The only reason I raise this is that there have recently been a flurry of papers suggesting that the old-fashioned protein selectivity ratio may be very useful in making a differential diagnosis between minimal change disease and focal sclerosis. I'll leave it there. I mean, I'm not going to speculate that this is indicative of an underlying lesion of focal sclerosis. I think the statistical probability is very high that this is minimal change disease, and the albumin to protein ratio is low because they're under detecting albumin.
So if I had to write a case report or a STEM for a question on minimal change disease, I don't think you could, except for maybe that, change anything about this case that doesn't scream minimal change. But, we do biopsies for a reason, and we can easily get fooled. And there's an overlap of focal sclerosis and et cetera. Dick, would you put the first top 10 minimal change, or would you cut it off at 5?
No, I wouldn't pick this down to 5 decimal places. I think the COVID vaccine is not just a red herring here. I think it has something to do with her presentation. There have now been several cases of new onset minimal change disease, as well as non-collapsing FSGS following COVID vaccine. And now that we are beginning to recognize that anti-nephrin autoantibodies may be involved in the pathogenesis of minimal change disease, this could be an acute anti-nephrin induced autoimmune reaction related to COVID vaccine.
But we have a little poll about this. Before I ask the poll, I mean, this just keeps coming up and up and up because people develop de novo glomerulopathies and they have relapsing glomerulopathy. And, we're trying to vaccinate every adult in the United States. So this could be a coincidence or it could not be a coincidence. So there's differing opinions. Certainly there's lots of reports, as Bill said, of relapse and de novo GNs associated with the vaccine, but these might have happened anyway. And it's very difficult to tell. And obviously there's reporting bias of people, that get the vaccine and have a relapse. And we're not reporting people that get the vaccine and don't have a relapse or don't get vasculitis or whatever it happens to be. So, Kavir, you want to put the poll out? Okay, very simple question. Do you believe that that is the nephrotic syndrome in this case related to the vaccine or not?
Dick, while the poll is going, have there been any reports of anti-nephrin antibodies in COVID vaccinated minimal changes?
Not that I know of.
A few more seconds. People put in your vote. It's really interesting. So pretty even, 54% saying it's not related and 46% it is related. And we'll get back to this later when we discuss the case a little more after we see what it is and any data that's available on this. Very interesting. So I think it's time to spin the wheel. Oh, wheel of wonder, who shall read the biopsy? Well, Pravir can't read his own case, so. All right.
You can read it.
I think I can handle this.
Give me a second here.
Yeah, we don't really know that this is minimal change, but I know all the fellows now are upset because they're like, it's a one time an attending gets picked and it ends up being minimal change, and we get some rare lipoprotein, glomerulopathy to read, and you guys get all the easy ones. I know what they're thinking.
I know. Conspiracy. Go ahead, you're controlling the screen. Yep.
Can you hear me, Pravir?
Yep.
Great.
Yeah, we can. I'm still on mic.
You're good.
Okay. So here we've got a core trichrome. Looking at the biopsy, there are lots of glomeruli. Beautiful specimen. Actually, you see gloms throughout the whole thing, implying that they were able to kind of skim the cortex and not go perpendicular to the kidney. Beautiful, beautiful sample. I don't want to say anything much else there, but I don't see any blue staining material to suggest any chronicity of the disease. I don't see any sclerotic glomeruli at this power, so looks really good. No big surprise. A healthy 30-year-old with a creatinine of 0.7.
I agree.
Here we have, this is an H&E, two glomeruli.
This is PAS.
You see, this is where I usually tell everybody I'm colorblind. It's pretty lame that I do that, but PAS. And we have two glomeruli present. They're filling Bowman's space pretty well. Capillary loops look open. I don't see any segmental scars. I don't see any segmental lesion. I mean, the real differential diagnosis here was minimal change, maybe focal sclerosis, maybe membranous, or who knows. So right now, I don't see anything that gives me a clue towards, this still could be focal sclerosis, and we haven't seen a scar yet. The tubules look pretty good. I don't see here a lot of protein reabsorption. The brush borders look good. This one maybe not so good here. But it looks pretty good, looks pretty normal for a 30-some-year-old patient.
Yep.
Same thing. You look at the mesangium. I think it's pretty normal. I think this is artifact up here. I don't think this is anything.
Yeah, I think that's where the origin of the proximal tubule is going to come off. So that's
Okay.
a little epithelium sloughed off.
Yeah, and the mesangium looks okay. I don't see any extra cells or much of anything. The tubules look pretty good. Nice brush border. I guess here, right here's a nice brush border. It looks pretty healthy.
Yep.
David, on that image, Dr. Rubin said, do you feel like the podocytes look a little more prominent?
No, I don't think so. I think that looks pretty normal.
So this H&E?
Yeah.
Okay. Much better view of the cellularity. you look here, there might be a few extra mesangial cells, maybe here, but that doesn't really help us in the differential of what we're thinking about. For the most part, it looks pretty normal. And again, the tubules look pretty well, they're well packed here and look pretty healthy. We often see ATN associated with minimal changes. Very common, especially in patients who present very acutely. And she presented very acutely, and we often can see ATN on histology without necessarily an elevation in creatinine. I don't know if there's anything going on in this tubule here. Maybe some damage. David, did you see
it was best seen on the PS stain, and they had brush borders, so I think
they
that's
all had brush
probably a
borders? Yeah, you didn't see any
fixation
sloughing?
artifact. Yeah.
Okay, all right. We'll go on here. Silver stain, beautiful stain here. Can really get a sense of the architecture with your mesangium here and your loops, and we're looking for holes, spikes, duplications. I don't really see anything. I don't see any holes. I don't see any spikes.
Yeah, they look smooth and intact.
Yeah,
Yeah.
and the tubule is a really nice picture here. Again, I would question this tubule over here, but you told me not to overread it, so I won't do that.
Yeah.
A lot of times we'll see on this stain some protein reabsorption droplets, but I don't really see that many of them on this on this slide at least.
Yeah, they look pretty much absent here.
It's so interesting about that finding because, you'd think if anybody would have a lot, it would be someone who's this acutely nephrotic but maybe, I don't know, maybe it takes time. I don't know. I don't have an explanation, but yeah, you're right, Bill. You'd think it'd be pretty prominent here. So IgG is completely negative. And I guess everything's negative. So at least from a standpoint that we have found no segmental scars and we found no immunoglobulin deposition, we weren't really expecting to, but you never know about a membranous. You can have a membranous that is so early, you don't necessarily see the spikes. So we'll look at the EMs here to confirm this. Here's the urine space, here's the blood space, here's a very nice capillary loop. And if I follow the base membrane here, there are no electron dense deposits. The mesangium looks okay, does not look expanded here. I don't see any electron dense deposits there. What's really, of course, very nicely shown in this is really diffuse foot process effacement, which is what makes minimal change minimal, as opposed to being completely normal.
Yep. Good.
The base membranes look a little thin here to me, but that's also, it's kind of a low power, and I don't know if we'll have a measurement or not. Or if
Yeah, we'll get a measurement at higher power.
Okay, I mean, they look a little thin to me. It's not something that's necessarily relevant to the case, although there's some hematuria. And in the chat, somebody asked about the hematuria. Bill had brought that up earlier, that our, Dr. Jendeska, our pediatric nephrologist, always points out that it doesn't bother her at all to see some hematuria, minimal changes.
Yeah, actually go back one slide, because there were some red cells in the urinary space.
Yeah, it's really nice. It's very right there.
Oh yeah, beautiful. Thanks, David. That's a really, really good point. Yeah.
Yeah, down at the bottom of the screen.
Yeah, right here and here. Yeah, that's really cool. I'm glad you brought us back to that. It's great. Here, a blood space, urinary space, and really diffuse foot process effacement. There's a couple of podocytes intact here, but for the most part, this is diffuse foot process effacement. And I think this is the mesangium's okay here, and we just see mesangial with other capillary loops. Pretty unremarkable biopsy, except for diffuse foot process effacement.
Right. And I think at high magnification we'll have a
higher power, the same thing. You can see that. Here's our base. Yeah, here's our, which is normal. They look thin, but you really need to measure them, and that's completely normal. So it's not even close to being thin. You can see the fenestrated endothelium here. Actually, here it's better, and then here's the foot processes here that are, pretty well fused, and a endothelial cell here. So.
Yeah, no TRIs in the endothelium there.
Yeah, thanks. So our diagnosis is, I guess, minimal change disease. Bill's finally right with his top 10. So Bill, what do you want to do with this patient?
Well, Yeah, I mean, I think getting her started up on steroids and pretty immediately is very important. We're using Bactrim now, and anybody with over the prednisone dose of 20. And I would start her off, I can't remember where her weight is, but I usually start patients off on about 60 milligrams a day with Bactrim. I think at a previous conference, we discussed anticoagulation in the setting of nephrotic syndrome as well. And minimal change, I typically don't do it because they resolve so quickly, but I've also done it before. Thinking about secondary causes, there was no NSAIDs. There's no evidence of anything here to suggest lymphoma. Certainly, there's no history of lithium. The vaccination, even if that's it, I'm not sure what to do about that. We'll still have to go ahead and treat with steroids on whether that's really causal or not. And we saw the poll that everybody was 50-50 on that, so I don't really have much more to offer.
What did you vote?
On I voted no. But I feel like this is about the same amount, but you know what? It's not fair. It's all anecdotal. I feel like there's about the same amount of minimal change we're normally seeing. It's the same amount of glomerular disease we're seeing. Everyone in the world needs to be vaccinated. It just, people are going to get glomerular disease, and they're also going to be getting their vaccines this year. So, but hopefully there's something more scientific than that can come out to prove or help out with causation as opposed to association.
Casey, what did you vote?
I didn't vote, but I would have said no because you told us not to vote because we're co-hosts.
But you would have voted no.
I would have voted no.
Dr. Glassick, what did you vote, or what would you have voted if you voted?
I voted yes.
Mm-hmm. And how strongly do you feel
I don't
about
know.
that?
I can't give you a good reason.
Yeah. Yeah, I would have voted yes, but I'm so biased because almost a day doesn't go by now that somebody isn't reporting some glomerulopathy that after COVID vaccine. I saw a lady in the office yesterday. She'd been with membranous, and she'd been in remission for, I don't know, 2 years now. And I follow her PLA2R every 3 to 6 months, probably every 4 months. And her PLA2R has been negative for quite a while. And lo and behold, her proteinuria, it's not up a lot, from maybe 600 to 1400. But her PLA2R went from negative to 60, not subtle. And she already relapsed once, so she has a tendency to relapse. Wasn't even thinking about COVID. I mean, it's completely on my radar lately, and I didn't even think about it. And then, we were talking, and then all of a sudden, I realized, wait a minute, when did you get the vaccine? I got it, 2 months ago. Who's to say, people with these diseases relapse, and yet maybe this is a reason. Something does this. I mean, it's not just minimal change that it's been reported with. It's been with a number of glomerulopathies, but who really knows? I think Dr. Baxley's gonna
I do like the idea. I do like the idea of thinking about it. I mean, our classic presentation, there's so many patients who have, let's say, some maybe underlying APOL1 or something, and then they get threatened with a viral illness, and then that sets them off into nephrotic syndrome or any kind of viral illness. And certainly, I think that the association of Covan to actual COVID infection is real. So I think it's very plausible that the vaccination could induce a viral like glomerular disease, and in that realm is focal sclerosis and minimal change. So I think it's likely. It's just really hard to pinpoint it down more scientifically right now. I'm not quite sure how that's going to be done.
Yeah, I'm not sure how it's going to be done either. I mean, I suppose if the general rates of minimal change, if we had a national registry went up, it would be, I think that would be easy. But we're really subject to reporting bias. So it becomes a real problem. Dr. Rubin, what are your thoughts on this case?
Well, it's hard to add anything to what was already said. In defiance of David, I thought the podocytes in one area were rather prominent, suggestive of the final diagnosis. The other point I wanted to make is when we talk about mesangial hypercellularity, this is something that was reinforced to my database recently by Dr. Agati. We need to evaluate the periphery of the glomeruli. We cannot talk about hypercellularity in either the hilar or central portions. So just for reinforcement. I wonder if, as I post in the chat, if RTIs or interferon prints have been described in COVID vaccine-induced GNs. We know that in certain viral-induced GNs that has been found. So I don't know. That will be the only clue that will help us say, gee, maybe this is in fact associated with the vaccine. And I voted, I don't know.
Yeah, well, it seems to be the virus itself that is associated with those with the footprint, whether it's HIV or parvo or whatever, or COVID, and maybe the vaccine's different, maybe not. We certainly didn't see any here. It would be interesting if we had a way, but we don't. So, Dr. Glassick, any more before I hand it over to Pravir to tell us what he did and what he thinks about the case? You have any more comments?
No, I think we've covered it pretty well, Roger.
Okay,
Thanks.
great. Pravir, take over. Tell us what your thoughts did, what you did, how she did, etc.
She, as people had mentioned, she came in classically with minimal change disease, and that's kind of what we thought. And we put her on prednisone right away, 60 milligrams once a day, along with Bactrim based on her weight. And we kept on trying to probe to find out if there was anything preceding that we were missing or that she could recall. And she said quite clearly, Thursday she felt great, and by Monday she had gained 20 pounds. And nothing else was new at all. And we did, multiple different ways to ask her questions. And so it was interesting that, we kind of went back and said, well, she said, oh, she had the vaccine, and we went back to see the timeline. And, I think that was the interesting part here of her presentation, is that this whole vaccine, as that people have mentioned, is it real? Is it just casual, a link? Or are we just, as I think Dr. Whittier said, we seeing GNs and now everyone is getting vaccinated, or we're encouraging it? Are we just trying to link it? And I think if you go into the, if you go into a PubMed search, and this is expanding, this is just from this morning. If you just type in COVID vaccine, and I'm specifically talking about minimal change, just so I could fit it on one slide, is you can see there's multiple reports, and some are responses to initial article. It's exploring more cases. And so this is definitely something that's being seen. And there's a wide variety of, different vaccines, Pfizer, definitely, Moderna, some other vaccines that we don't have here in the US. And the timeline of these responses and these presentations of these patients after the vaccine is variable from, anywhere from days to months, usually less than 3 months after, the administration of the vaccine. And some of them are new onset minimal change, and some are relapses. And this holds true not just for minimal change, but other GNs, as Dr. Robbie said, membranous. We're seeing other autoimmune disease of GNs also being flared. And so I think there is something here that hopefully we will be able to further explain. And as we see more of this, we'll find out a better, is this real or not? But if you look at this is a nice table, and I got this from NephJC, and this is courtesy of Swapnil and Joel Toff, who have accumulated a ton of data on COVID and now the vaccine. And so I do recommend everyone go and check out the NephJC resources on this. But if you look at just minimal change itself, this is going to be outdated by next week. But you see the timing and the amount of different patients who've had it. Some have been new diagnosis, relapse. And this one is a little shorter, but I've seen patients who've gotten it a little after, more than a week after, but from days to weeks after either first dose or the full vaccine. And most of these have been, steroid responsive. And a lot of them, interestingly enough, you go back, a lot of them had AKI, which, we see in minimal change. Now our patient didn't hear, but, classically, we see, normal kidney function, no normal tension, and just a severe proteinuria. And a lot of these patients did have AKI. And I wonder if it's just the abrupt onset, which we always see, and maybe the vaccine somehow plays a role, but a lot of these had AKI more than we typically see. IgA, and of course RPGN has been described, crescentic IgA, vasculitis, they've all been described with this. So I think this is a ever growing literature that I think we need to explore further. And
so I was wrong, Pravir. I think I was wrong. I also said that FSGS has been described, but it looks like no one's really reported that.
Nothing here that I could find, but that doesn't mean that next week we won't have one, right? And I think that's the biggest thing. I think this is just growing and growing. So maybe there is a case that's maybe it's been submitted and we haven't seen it in the literature yet. But no, I wouldn't be surprised if we do see that though. And so what in terms of minimal change, how do we put this together? What are the hypotheses, or what's one thing to think about is when we look at the pathogenesis of minimal change, and I'm not going to go into this in detail, but there is a role of T cell dysregulation, and we know that there's different reasons why we believe that, anywhere from patients who have minimal change disease more frequently, patients who have Hodgkin's lymphoma get more minimal change disease, and thinking about T cells there. We think about atopic individuals who are higher risk of having minimal change disease. We think about the allergy connection. And so there's definitely a known literature and thought of the pathogenesis of minimal change having T cell dysfunction. And so one thing I found interesting was that when you read more about the vaccine in these cases, there is a thought that specifically the Pfizer, maybe more than the others, have induced a very robust T cell activation. And is that why we're seeing relapses of minimal change disease as well as de novo kind of minimal or new minimal change disease with these vaccines is a potential possibility. And this was from one of the articles that was published, and this is kind of one of the pathogenesis that was thought about, is that there is a strong temporal association, and maybe it is because of this rapid T cell mediated immune response that we get with viral mRNAs in general, and that is triggering podocytopathy, and that's why we're seeing these minimal change disease. So I think it's very interesting, and I would have voted yes, even though. Go ahead.
In that table, did they mention at all what vaccine people got?
Yeah. So this table, I'm sorry. This table. So this is I believe the Pfizer. This one, I believe I have to look up. Don't quote me. Is a different one, and maybe the Moderna. I'll have to look that one up. But these definitely different vaccines. If you see a lot of them, seem to be the Pfizer.
But if it's Pfizer, I mean, maybe that Pfizer gave. It may just be more people got Pfizer, but at least in the minimal change section, there is a lot of Pfizer vaccine. Kind of supports your potential pathophysiology of T cell activation. And I don't know if the Moderna has less T cell activation either, for that matter.
Yeah, and that's the question. I don't know. And so the BNT 162b2 is the Pfizer, and the mRNA 1273. I'm sorry, 1273. This is Moderna. So it definitely is described with both. So I think that's the interesting part here. And there's one more thing I would like to share. There's another article. Let me see. I'm going to share my screen here. This is courtesy. Was recently just published in nephrodialysis transplant by including Dr. Javeri. If you look at this, again, looking at vaccines, and I'm trying to blow this up a little bigger here. You can see that. Again, 7 days post-vax, multiple different timelines. And it's interesting, if you look at again, like I said, AKI, a ton of AKI, but they respond quite quickly to steroids, 10 days, 2 weeks, remission, no change. Some of them didn't respond. And here's one more table that this was of patients who had crescentic GN. Again, high dose steroids, 2 weeks shortly after the second dose, so kind of a wide variety of duration. So I think there is something there, and I think time will tell. But let me go back to my presentation here. Let's see. So what happened in our case? So we started on prednisone, 60 milligrams a day with Bactrim, and this was for presenting labs. This is 10 days later when I saw her in clinic, and mind you, 3 or 4 days before she even came to clinic, she messaged me and said she feels back to her normal self. Can she stop the prednisone? That was the message. And sure enough, I said, no, come into clinic. And we got labs. So this is 3 days after she's already feeling better. Her albumin has gone from 1 to 3.4. And her protein we can't quantify, it's below the lab, lower limit of the lab. So it's more or less negligible. And her weight is down to 130 pounds. So
I mean, maybe we could stop the diuretics, but not quite yet on the prednisone.
Exactly. So I did. She was on Lasix, I should say. I stopped that right away. But this is after, really after 7 days, she had a response. And this is 10 days later, she's in there. So a couple of things that were helpful for me. I didn't have to deal with anticoagulation because that was the next step I was going to talk to her about. I was going to put her on Eliquis, but I didn't have to do that. and so she feels completely back to herself. And so I think this part of this was, I don't know, and I want to ask, does this response change anyone's answer if this was vaccine related or not? Or is this just one of we see a variable response rate to steroids? Now she's responding more like a kid very quickly, but this can happen in adults too. Does the response time change anyone's thought process on vaccine related or not?
Well, I think you've answered the question in a way, because you can see this.
Mhm.
But
me, it
what
did.
is remarkable to me is the fact that a lot of the cases that were presented did respond so quickly. And you can see it. I don't think it's that common in adults to respond this quickly, to have a diuresis complete. I mean, within a week, she was pretty much back to normal. Does that mean it is or it isn't? I don't know. To me, it's interesting that other people have reported this very, very rapid response. It's interesting. It comes on very acutely and it goes away very acutely. But again, I don't know if that leads us closer to the clue of pathophysiology related to the vaccine or not. Anybody else have an opinion on that?
Yeah, and I think minimal change can also do this idiopathic. I think the only real way to tell will be following her. If she relapses and there's not another dose, well, then I think that would answer it. Certainly, I think Steve Corbett had a case of a Voltaren gel-induced AKI with minimal change that we were pretty all convinced that it was related to the Voltaren gel. And she's actually already relapsed when she wasn't given Voltaren gel again. So really that one ended up being an idiopathic one. So I think the relapse will help. But the real point is if she gets a third dose later on, just as was in the chat, what are you going to do there? That's a real tough one.
Yeah, so I'll just, for people who didn't see the chat, the question basically is, if the CDC or whoever recommends that we all get a booster dose, is this something that you would avoid in her? I mean, who knows the answer to that, but it's a really good question. And again, I don't have an answer for that necessarily, but it does bring up a really good point. And another question that was brought up was, what if we start vaccinating kids who have a lot of minimal change disease? When it's opened up to all children, maybe we'll see a flurry of minimal change coming back. And if that's the case, we may have our answer of cause and effect. And it's going to be concerning. I mean, we don't want these kids to, all have minimal change again. It's not it's easy to treat, and then most people go into remission, but it's not a benign disease, and it's not benign from getting steroids and everything else, nor is COVID a benign disease, and maybe even a worse disease in kids with the new variants that are out there. So, I mean, it's a real problem and a real concern. I don't think anybody's going to not vaccinate their kid, but I hope we don't see a flurry of minimal change relapse, as was proposed. So before we end this, I want to open up the poll again. And now that we've had a really nice discussion, let's see what people think. I want you to revote. You can revote with what you believe before, or you can change your vote. You can keep your vote no matter what, but we want to see if we change anybody's mind. It was about 50-50 before. Wait a couple more seconds here. Anybody else want to vote? Okay, we can end it and
Shared.
Yeah, so it didn't move as much as I thought it would move, quite frankly. So I give credit to people that hold their own. I'm totally swayed to the yes, but I was pretty much a yes before. I'm surprised it's not more. Actually, Pavir and I talked about this beforehand. Well, what if it's 90-10 at the beginning or something, or if it's all 100%, because we didn't know which way it would go. So I'm really glad that there's a mixed vote on this, and that we changed people's ideas a little bit. I think it was a great discussion, Pavir, and brings up a really important point with a lot of real good questions for the future. But as Bill said, I'm not sure that we'll ever figure this out. I'm not sure that there's a good way of figuring it out. And if we don't, that's fine, because that'll mean COVID is over. And I think we're all ready for COVID to be over. Anybody else have any more comments on the case? Great. Well, we'll stop early for a change. Thanks, everybody. I see some new faces in the audience, a couple programs, a couple hospitals. Welcome. We hope you enjoyed it. Join our YouTube channel, and please come back and tell your friends. We had a new record today, somewhere around 60. So thanks everybody for coming and for being good sports with the poll, and stay safe, and we'll see you all next week probably.